Thank you, Guy. Thank you, everybody. So we're going to start, before we start the discussion, we're going to view the results of a survey that was carried out with CHAM and the Ipsos Institute on the level of acceptability of populations in 5 different countries with respect to the fact that nurses could be involved in more medical acts. So in terms of an analysis prescription or X-ray prescription by a trained nurse. Look at the results for Sweden, France, Portugal, Italy, and Germany. Then we can move on to the next slide, please. So prescription of medical treatments for common healthcare by nurses. You can see again, Sweden and France are leading. 81%, 74%. And then the third slide is for small surgical procedures. So what we're seeing from this survey are a number of messages where Sweden and France are leading the other countries. People are ready mentally. And the further east we go and the further south we go, the lower the acceptance. And it's for surgical procedures that the level of acceptance is the lowest. So I'll start with you, Mrs. LALIBERTÉ. Thank you for coming. And in relation to the introduction and the interview, and given the survey, what is your status in Canada? How were you trained and how do you go about things? In fact, in Canada, I come from Quebec. So our province is a little bit behind in terms of the development of the role of nurses compared with other provinces in Canada. Our training is very advanced. We've got a collegial level, and then we have a number of years at university. Then we have to work for 2 years in a speciality. That's a minimum. And then we have to go back to university, and we already have to have a certain amount of experience. Then we do a master's and then a specific diploma before we can work as a nurse practitioner. So it's training that is quite considerable. And there are 5 specialists in Quebec. There are nurse practitioners like myself who are dependent on family doctors when it comes to the patients. And then there are nurses specialized in working with adults, working in hospital centers, over 18-year-olds. And then there are pediatric specialists. And then we have other specialities and neonatal specialities too. So my practice, let me talk to you about it. So we share a certain type of training, but then we consolidate our knowledge. We are involved in additional medical actions. We can now prescribe medication. There's no restrictions here. We can do imaging. We can do X-rays. We can prescribe laboratory analyses following the monitoring that we do. We can follow chronic illnesses, we can follow pregnancies and children, and we can also set appointments. And there are other issues that we encounter. We have to deal with bronchitis, people who faint, and we have to manage all of this. We're not allowed to actually make diagnoses. So we're behind other provinces in Canada. We have to prescribe before diagnosing. But when we prescribe something for pneumonia, we're not allowed to say so. So that's the common health kind of health care. In terms of chronic healthcare problems, we can monitor patients. We can start treatments for 6 illnesses without seeing the patient beforehand. So for diabetes, hypertension, asthma, chronic illnesses, and others. For other chronic illnesses, we have to refer to the doctor in order to make the diagnosis. We do the assessment, and when we know that the patient has a chronic problem, for diabetes, we then go back to the doctor, but we continue to follow our procedures. So that's basically what nurses do in Quebec. Thank you.
Story that was just depicted by Ms. LALIBERTÉ resonates with your own activity and own experience in the UK?
Yeah. So basically in the UK, possibly we are more advanced compared to Quebec. We take our role directly from the US. And I know the audience might be skeptical, but it is. I'm a surgical care practitioner. I just qualified literally a week ago after 2 years of intensive training.
Congratulations.
Thank you. And And we take essentially, as I was saying, our role from the US, from nurse practitioners in the US. Okay. The very first surgical care practitioner who started this role was Susan Hall in 1993 in cardiothoracic specialty. We are highly specialized in one single specialty, while there are advanced nurse practitioners who are more generic and cover more the medical aspect rather than the surgical. There are some differences between us, surgical care practitioner, and advanced nurse practitioners. We mainly work hospital-based, theatre-based. We work as first assistants during surgery, so we are directly collaborating with the operating surgeon, but we can also perform procedures on our own. And there isn't a list of procedures we can perform. It's all about your experience. Where do you work? How are you based in working? How the consultant trusts you, and what he allows you to do. The
consultant, you mean the doctor?
Consultant, yeah, is the doctor. Okay. The reason why this role was introduced is because we were seeking a little bit more stability in the surgical team. In UK, doctors train for 6 years at university, and then they move on to foundation year for 2 years, where they rotate specialty each 4 months. And then they move on to core trainee, where again, they rotate every 4 to 6 months in different specialty. Only after these 4 years, they will move on to the specialist training. And even then, they will be in a certain hospital for 1 year only and move to another one to complete that training. That's why what we were seeking was a little bit more stability with the patient care. And surgical care practitioners are permanent member of staff, so it is a bit better from the patient perspective to have a figure, to have a role that they recognize as being there consistently and present all the time. We are involved in all the aspects of patient care, starting from the preoperative assessment up until the after surgery. So we will see patients in clinic, during surgery, if we operate on them or if we assist, and we follow them up in clinic as well. So we have also, especially in my organization where I work, we do have a surgical care practitioner-led arthroplasty clinic. I work in trauma and orthopedics, specifically.
So you do arthroplasties?
We do assist for arthroplasty. We don't do them on our own, of course, but we do assist the surgeon.
And can you tell us just in detail some examples of the peculiar activities or interventions that you are allowed or that you are used to perform?
Yeah, so basically we can, starting from the pre-op, we can prescribe x-rays or ultrasound scan or CT scans, depends what the patient needs. Only for magnetic, for MRI scans, we will need the consultant signature for that. Okay. But for x-rays and everything, we are allowed to prescribe those. We are allowed to prescribe medications if we have the training to do so. And it's another 6 months course that you have to undertake before you're able to prescribe drugs. We can prescribe blood tests or any other investigation that we retain useful for the patient. And then, sorry, I got lost for your question.
No, the peculiar intervention that you perform by yourself.
By myself, I could perform a manipulation under anesthetic of a fracture with then
which
all
is
the
tricky.
cast, which is tricky. You don't always get it right. And I could also perform a manipulation under anesthesia plus insertion of K-wire, for example. Okay. Especially in kids, it's very common to do so. Or I could perform a debridement of a wound entirely on my own with application of specific dressings after. Or I could perform injections in joints, which is what I'm currently doing right now with my consultant. Sorry, for arthritis, for treatment of arthritis. So all these steroid injections. Okay. And that will happen under X-ray guidance, of course. Carpal tunnels. This is just to mention some examples, but the amount of intervention we can undertake is very extensive and depends as well which specialty you're working into. For my cardiothoracic colleagues, for example, they do the vein harvesting on their own while the consultant is operating in the chest. Okay. So they will perform the vein harvesting and then move on to assist the surgeon for the procedure.
Thank you very much. Tatiana, je vais vous demander de...
Etienne, would you like to react? So there's a whole range, quite a high range of possible activities for your colleagues who work in the United Kingdom and Canada. Can you tell us a bit how you were trained? Well, in France today, we have We've got a university training. We have to have 2-year training to begin with after professional experience of at least 5 years. 3 years. There are 4 types. I was one of the first students to be trained as a nurse practitioner. Yes, or the equivalent in France. Yes, in fact, we're specialized nurse practitioners. So we work on chronic pathologies, kidney problems, transplants, and mental health, and so I focus on. We've been trained to monitor for 8 chronic conditions. This includes, assessment, collecting data and assessing, clinical conclusions, orientation, screening, taking into account different things.
We take into account all of the patient's life elements so that we really understand his personal healthcare itinerary. We also, my colleagues were talking about prescribing additional exams, tests, anything that helps us monitor the pathology. We are allowed to do so. We're authorized to do so within the area of our authorization. So this is what you've started doing already? Well, I haven't started myself personally because I'm a visiting nurse and we don't have any economic model yet for this. The convention is currently being negotiated in France with the partners, the unions. We weren't able to attend these negotiations. We weren't able to explain what we did in the field and how we're going to reapply this diploma to the organization of primary care. Today, what is proposed is not at all in line with what we expected. We have one part that will really be clinical monitoring, where we will collaborate with the doctor, and as in complementarity to what the doctor does. My colleagues were talking about diagnosis, whereas we are more focused on monitoring. So the follow-up or the monitoring part will be remunerated with a certain price that we don't believe is appropriate. We don't think it's enough for 160 euros per year to follow a patient, for example, with a pathology. So we don't think that's sufficient. What is proposed as a remuneration will make the visiting nurses even poorer, we believe, those who are interested in this orientation of their profession. Today, we can say that this career opportunity in a clinic will allow better recognition and better positioning of the nurses with the patients within the healthcare system. We will have a role today that's much more a supporting role. We talked about this morning. We've seen the organization of these maisons de santé in France, these healthcare centers. We've seen these regional health agencies. And yes, this is being organized. And pathologies, clinical pathologies, are a problem of tomorrow, and we will be able to really work with the doctors together. But it's not only working with the doctors, we work with all of the other healthcare professionals. It will be interprofessional collaboration. Tatiana?
Of the graduation, est-ce que vous voulez nous dire, do you want to tell us a little about the additional income that you could retrieve from the graduation itself?
Yeah. While a newly qualified nurse in UK would start from a £24,000 per year salary, in UK we are organised in bandings. So the higher grade you are, the higher band pay you are. As a surgical care practitioner and advanced nurse practitioner, you will start from a basic salary of £37,500 per year, up to arrive until 60, 70,000 based on experience and based on how you progressed in your banding. So obviously, your progress, what you study, what you do, it's recognized in terms of pay. And together with that, if you work in the public sector, you're allowed to work as well privately, hence increasing your income in that way. They will not make you a problem for it. And other than that, the hospital will also pay your university fees.
Okay.
The hospital will train you, will invest in you. And that's how it happened with me. I was hired as a trainee, surgical care practitioner, and the hospital has paid me my basic salary, plus the training.
Okay, so you perceive it as a good system. Good.
Absolutely, yeah.
Madame Laliberté, vous voulez nous dire, on voit que le supplément de...
So yes, we see that the additional income is usually between 10 and 25,000 additional pounds with respect to the normal nurse's salary. Yes, in Quebec, the nurses are paid by the state, so the salary is between 60 and 100,000 Canadian dollars per year. As for training, there is a ministerial challenge here. They want to have 2,000 of these nurses by 2024, 2025. So they're giving scholarships right now. The ministry and the government of Quebec is trying to facilitate training because some people need to stop working to go train, and so this can cause issues. So you need to stop, get trained, and then go back. And this is a real loss of salary. So there is a lot of support from the government of Quebec to help people with their training. Another point is that you can really see the role changing in Quebec. We've had two main regulatory changes in the past 2 years. Next year, nurse practitioners will be able to make diagnoses in Quebec. We don't know the extent of or the limits to this, but it would seem that for the most usual diseases, for all of the patients that come without an appointment, for example, we'll be able to pose a diagnosis. So this will certainly have an impact on the salaries of the nurse practitioners, depending on the level of responsibility that they will be entrusted with. Most of us, before we had patients that we were in charge of, this can vary from 250 to 1,000 patients. So we're not sure. If you work in a medical clinic, you have more patients, but we always work in collaboration and in partnership with doctors, but also with, as you said, all of the other healthcare professionals. And the doctor is at the center, but the doctor really wants to work, and he really is with us as a team, and he really thinks that we can offer better services that respond better to the needs of the population. So yes, it is more attractive, this additional remuneration in Quebec, than the one that you were offered here in France. Yes, in France, we are dealing on the one hand with the private nursing practice system and then the public sector, but the salaries that were proposed are quite low in the public sector as well. Today, we have an innovation and a proposal with a care offer that's a bit different. And we had imagined that this would be encouraged and valued. And why not innovation in remuneration? We're not asking to be paid per act, but at least we should be able to live with a decent salary. Obviously, this is a bit of a wager. People have to trust us. But yes, today we support the orientations that have been given by the government with the 2022 plan. These advanced nurse practitioners have been proposed since 2016, and we really support this reorientation of the care offer, promoting health education. This will be our role. In addition, we are a wonderful lever for all of this, and our message is give us the resources so that the nurses who are trained can do their job. There are about 500,000 nurses in France. This would correspond to the budget that's being reimbursed. Well, I'm not sure about those figures. I will let the decision makers make those calculations. But yes, there are some calculations that they should be making. We might be helping them save money. Patients who are monitored for mental health, for example, Madame Vonner has just issued her report saying, yes, the reorientation of the psychiatric system should take place, and it should be 80% ambulatory care now. This is a target. Now, today, this reorientation can only be done with the support of the professionals and in collaboration with the healthcare professionals. And I've lost my train of thought. I'm sorry. Well, let's take this opportunity to ask you.
Doctor that you have, is it easy? Is it very collaborative as a process?
Yeah, in UK, the relationship with the doctor is very collaborative and constructive. The doctor will give you constant feedback on how you do and how you perform, and will support you in your role as well. They don't see us as a threat towards their training, towards what they can do. They see us as their support, especially because now UK is facing a shortage of junior doctors, as in the whole Europe, I believe. And they see us as a real support, especially when they struggle on the ward to review the high amount of patients that they have. We will step in if we are free in our daily schedule and help them out in reviewing patients, in doing referral letters or discharges, etc. So we really have built a complete network of support around them, and they know they can rely on us whenever they need us.
So the level of trust is good?
Yeah.
Okay. Madame LALIBERTÉ, on sait que le Canada...
Madame LALIBERTÉ, we know that Canada also had a shortage of doctors. Apparently, you have more, but can you tell us about your relationship with the doctors? Yes, usually, I think the doctors who work with us, it goes very well because they know our training, they know our role, they know how rigorous we are. We work with the same practice guides, we have the same approach in the assessment of the patient. So where we're different is in our approach as nurses. The way we're going to work with the patient, we're quite complementary. The doctors are a bit reluctant when they don't work with us and they don't know how we work. And so this question of change, it takes time to change mindsets, to see how things are going, and to understand that we can work together. There's a real lack. There's a gap here, so they need us. So we really have complementary roles, and we don't want to replace the doctors. And obviously, we are there just to contribute our complementary forces to the care that we give to the patients. We want to improve accessibility to the services. The main objective is to make sure that the patients can have an appointment faster. So we work side by side to receive the patients in our offices, and we try to support each other in the different services or the different wards to make sure that we're present. But to really improve the accessibility, yes, there is a certain resistance to change. That's normal. We see this everywhere. But it takes time. And we need to get together and talk about it just the way we're doing it here today, to see that there's no threat, that we're all rowing in the same direction with the same objective. Have you been evaluated or assessed? Yes, during our practice we are assessed because we're working in a partnership. So when we were carrying out if we carry out any inappropriate acts, the doctor can say, wait, you shouldn't be doing that. But normally, we have a certification to validate our skills before we start working. So we're really there to work together. And you can see this every day. They're not observing us and assessing us because we discuss the cases together with the doctor, and they see that I know my limits and I'm not going to surpass my limits. So it's really a question of recognition, of knowledge and recognition of the roles and exchanges to make sure that we all are on the same page concerning the care that we want to offer.
NHS, the National Health Service in the UK, made any kind of medical assessment, of economic assessment of the reform that was implemented when the nurse practitioners were trained and executed on the market?
I am not currently aware of this, but it has been demonstrated towards various studies, from various studies, that the introduction of nurse practitioners' roles in general, whether as surgical care practitioner or advanced nurse or specialist nurses, has improved the quality of care that we deliver towards the patient, because the patient has got a role that we recognize as being there at all times. And in terms of economics, obviously it has gone towards saving money as well, because we are there all the time. We are employed as a permanent member of staff. They don't have to record to agency doctors, for example, to fill the gaps. And I know it can be perceived as a gap filler at some times, our role, but it serves the hospital to have a continuity and guarantee that continuity, especially as well from an economical point of view, also saving money. Because a doctor working locum shifts, agency shifts, will cost you more than a permanent member of staff, of course.
OK, thank you very much. Tatiana, vous voulez réagir à ça? On a l'impression que c'est une activité.
Did you want to react? It seems to be it's an activity that's medically and economically mature. Yes, today we have the experience. These are very inspiring models for us in France, that's certain. Today, I think we still have a lot of work to do to assess our own practices. But we need to already start working and start acting as nurse practitioners. What she said was very interesting when she talks about continuity, because indeed, the nurse's role is a clinical role where we are monitoring the patient in the clinic. And there's also this role, the cross-cutting role, where this reassures people a lot, because we have people understand the system better, and both in the establishment and in primary care in the field. And this is what will give added value to the system. Let me take at the level of the patient, we'll be able to work on their care path and their life history, their health history of an individual, personalize it. And this will have an immediate benefit for society. There'll be no redundancy of these it'll be a savings. There won't be any redundancy in terms of blood tests, etc. And we will be able to reorient, because this is one of our roles, or orient the patient according to the problems they have. We'll be able to react to the risk factors, react to the quality of life of the patient. So today, it is a model what they are doing in the UK, and we really need to buy into this in France and introduce it in the healthcare field. We are ready. We are trained. And have you met doctors yet? Met with doctors to understand what was their acceptability level? Yes. As my colleague said, we work in partnership, in collaboration with the doctors. The added value, everyone can see it. We have a good level of trust. And today, yes, in the field, it really is working well. Thank you. Annalisa?
The activity that you perform?
Yeah, of course, as all the healthcare-related professions and the medical profession, you are liable towards your patient. You are accountable to the patient, you are responsible to your consultant, but ultimately, if things go wrong, the patient can take you to court if you've done something wrong.
And does it happen in the UK?
It does happen quite often. British people are really keen on getting things done perfectly. Otherwise, people can sue you very, very easily, legally, I mean. The hospital will offer you a certain insurance cover to cover yourself from this liability problem and all the court problems, but ultimately it's always down to you and how you do things. It is very important you document every single thing clearly, in such a way that if anything has to go wrong, then you know you've done the right things, you've taken the right steps to do the things as they should have done. It's important you follow the policies, you follow all the protocols, and each hospital in the UK has got its own policies on how to do things and how to follow, apart from all the national guidelines that are available as well, and you have to adhere to, of course.
OK, Madame LALIBERTÉ, vous avez ce sujet aussi de responsabilité juridique.
What about the issue of legal responsibility? Well, yes, in our countries, we have the legal responsibility. A doctor is not responsible of what I do within the frame of my activities. Usually, we work autonomously, so I choose my interventions with my patients. We don't have many lawsuits in Canada amongst nurses. Usually, if you listen to your patient, you don't risk any legal issues. So we are very careful about our patients, and we try and answer appropriately to their needs. Another important thing is continuous training, and we do that with partner doctors as well as within nurses associations, and we try to do that so as to adopt collective guidelines and standards practices so as to prevent any legal issues. Of course, we are not totally exempted from this, but we try not to think about it on a daily basis. Are you familiar with the French legal framework which will go along the new status of nurses? Well, yes, we have new legal frameworks, and we have the obligation to be insured now. We have civil responsibility insurance. Now, this is only beginning, so we don't have so much experience or law cases to refer to. Of course, this goes along with an obligation to get continuous training, and we should be trained so as to offer this personalized accompaniment. And we are putting everything together now, but as we are independent workers, it depends upon us we have to take it upon ourselves to get organized. Yes, we don't have a clear vision on the visibility that you have, the perspectives that you have in the future. Do you know what it will be 3 or 4 years from now? Well, we lack visibility, as you say, and we also need to inform the public about our new status. We need people to become aware of what our future role will be in the field. All the nurses have a professional project. Now, when you are in a profession, you become an expert in your area. I work as an independent nurse since 2003, so I know the professionals with whom I work. They trust me. We have that visibility in the field. What's difficult is the relations that we have with the institutions. This new functioning must be put in place, and this is not easy. We hear about nurses in advanced practices everywhere. Now we need to hear what they have to say about that. In France, we have about 60 young graduates per year as advanced nurses. We will have 350 next year, perhaps a little bit more. We don't have exact figures yet. And figures will keep increasing exponentially because this is a very interesting development for nurses. It attracts future nurses. I was at a meeting the day before yesterday, and nurses were now allowed to follow some trainings which they were not allowed to attend so far. So this scheme is going to be deployed all over the French territory. And we will be present as nurses in all the fields of specialty. So this is being put in place right now. It offers very interesting perspectives. Thank you.
To implement the reform in the respective countries that you represent. because it's an old subject. The first clinical trials were in 1971 in the New England Journal of Medicine, randomized trial in 74, and medical economic evaluation in 78 with an editorial associated that was named the Medicine Without Physician. So how long did it take to be actually implemented?
From 1993, when Susan Hall actually started our role, it took us until 2006 before...
So 13 years.
Yeah, 13 years before the Royal College of Surgeons could approve a framework for us. And according to that framework, the university have to adhere to that framework to train us. So there's only actually currently 3 universities in the whole UK who are accredited by the Royal College of Surgeons to undertake this training.
OK. Et au Canada, alors, ça a pris du temps aussi?
Oui, au Canada.
What about Canada? In Canada, since 1960, it's been in the air. In Quebec, it's only since 2005. We had our first specialized nurse in cardiology, or nephrology, or neonatology. And we have only 550 graduates now, out of 74,000 nurses in all of Quebec. So there's a lot of work. There are many positions available. We'll have to stop there. Thank you very much.